So
You don't have summer.
but
I'd love to. Oh, I'm gonna read it. Just everything.
You're unmuted and all that, so once you're good to go, we have to just start talking. And the recording's done,
Shall we go ahead and start, or shall we wait for?
I think we should give it a couple more minutes.
Okay.
I'll let you know when there's a close to the link. We need like 10-15 more online. And then
Okay, sounds good.
then
None?
start. Yeah.
Let me just stand up for a minute.
Okay, we're good here, right? So what I'm gonna do, I'm gonna make this smaller. Here's the fill. Thank you. Okay, we're starting. Hello, everyone. Thank you for joining online in person. I'm very excited to introduce Dr. Meredith Wadman, who is a senior reporter with Science Magazine and author of The Vaccine Race, Science, Politics, and the Human Cost of Defeating Disease. She has covered medical research from Washington, D.C. for over 25 years, including working as a reporter for Nature and a contributing writer at Fortune. Her opinion articles have appeared in the New York Times, the Washington Post, the Wall Street Journal, and Time. She has appeared as an expert guest on NPR Science Friday, WMU's 1A American Public Media's The World, and elsewhere. She's a graduate of Stanford University and the Columbia Graduate School of Journalism. She began medical school at the University of British Columbia in her native Vancouver, Canada, and completed her medical degree as a Rhodes Scholar at Oxford University. As a medical student, she worked in health clinics and hospitals in Ghana, South Africa, and Borneo. Today, she's going to talk. Her work that she's going to present here is supported by the Pulitzer Center for Crisis Reporting. Dr. Wadman traveled to Durban, South Africa, to investigate health conditions for Black children there. 30 years after the demise of the Apartheid regime, Wadman will describe what she found and what was also an intensely personal journey. In 1986, during a brutal crackdown on dissent by the Apartheid regime, Wadman was a visiting medical student in pediatrics at the largest hospital for Blacks in Durban and at a remote village hospital. How and how much have things changed for South African children's health since then? This is what we're going to learn from her talk today. Thank you so much.
Thanks, Nero, and thanks for your welcome. And I'm so pleased to be here. Thanks also to the Pulitzer Center, which funds journalists to go all over the world to report unreported stories of people in crisis. So I'm very grateful for their support, which allowed me to travel to South Africa last July. So it's not advancing.
arrows aren't working.
Okay.
There we go. So essentially, I'm recalling back this experience I had in 1986, and then as a pediatrics elective medical student, and then looking at what was different by the time 2022 rolled around for Black kids there. So in 1986, is it possible to get rid of the stuff at the top or no?
Yeah, let me put it to the bottom.
Okay. I went to South Africa as a visiting medical student at King Edward Hospital in Durban. This is the hospital pictured from across the street from one entrance, and this was a typical line on a given weekday. This was the only hospital for tertiary care center for Black people in the entire province of KwaZulu-Natal, or what was then called Natal, which is about the size of North Carolina. Oh, come on, still doesn't want to advance. I don't know what I studied under Jerry Kuvadia, who was the head of pediatrics at the hospital and in the affiliated medical school. He was also a leading anti-apartheid activist. He was obviously much younger. Today, he's an elderly man, but he was very outspoken, very brave in a time that was extremely dangerous in South Africa to be those things. So he would also lead the coming battle against the HIV/AIDS epidemic, which had yet to rear its head when I was there. He was especially on the vanguard of understanding and fighting mother-to-child transmission of the disease. He also, he made me so welcome and obviously had a huge influence on me. I would go to his house frequently in the evenings and got to know his wife and kids. And then as a price for his activism, about a year or two after I was there, his house was bombed by agents of the government, and he and his wife and daughter only escaped because they happened to be in the backside of the house and the bomb was placed at the front. So it really just took enormous courage to do what he did, and I've never forgotten that. What I saw at the King Edward Hospital, and also during some time I spent at a remote rural hospital, actually drew me away from medicine and towards journalism. And out of my experience at the King Edward particularly, I was able to publish my first journalism article in the Canadian newspaper, the Toronto Globe and Mail. And that really had an impact and kind of sent me on a different career trajectory. So I feel lucky to have found the right career for myself, and also a place like my current employer, Science Magazine, where they allowed me to go back in July and to report in the first person, which is really rare in our pages, because it was a personal journey reflecting back on my time there nearly 40 years ago, and then what I found there today. So this is the article my talk is based on. It was published in November in Science. Small Victories. It's not behind a paywall, so if you have curiosity about following up, feel free to do so online. So 3 focuses for then and now in this talk, which I'll try to keep to the time limit: infectious diseases and vaccination, HIV/AIDS, and then infrastructure and access. So first, the general political context in 1986. The apartheid regime had kept the races separated since 1948. This included hospitals. The King Edward, as I mentioned, was it for tertiary care for Black people in the province of KwaZulu-Natal. And by the time people got there, they were often very, very ill. It's also a time where the government had imposed a state of emergency to quash dissent. The hospital itself was cash-starved and decrepit. This is a view from one of the windows. It was a huge, sprawling 2,000-bed place, built in 1936, thus its namesake, who abdicated the British throne like 1 week after this hospital opened in his name. It was horribly overcrowded. This is a scene from the neonatal nursery. And again, there was the thrum of political violence, which was especially apparent in the emergency room. And I discovered going back last summer that I'd kept these copious diaries, which I'd completely forgotten about, in 1986. And I'm just going to read you one scene from from a doctor. This is actually from a different health clinic than the hospital, but it's representative, a clinic in a township near Johannesburg, actually, that I also briefly visited. And this was one of the physicians talking. A stabbed liver on a Friday night that died, a stabbed heart on Sunday night that died, and a dead and arrival gunshot wound from a police bullet on Tuesday night. And it's not even Christmas yet. Do you know that a stabbed heart in Soweto is a weekly event? Last Christmas, they had 5 stabbed hearts on Christmas Day. And then this is talking then about, this was December 17th, 1986. And I'm writing now about my own experience. It's early, the roadblock slides past and we turn through barbed wire into the clinic. 500 patients per day, 4 full-time doctors, small army of part-timers and nurses. It's strictly private and it's run on donation. That means that the staff can turn away government agents and police who sometimes come here in search of their gunshot wound victims. Tuesday night, the latest victim of police shrapnel didn't survive to be arrested. They're expecting worse in these next 10 days. The United Democratic Front Christmas Against the Emergency campaign could lead to anything, thus the heavy police presence in Soweto, thus perhaps the death of a white soldier we hear whispered under breath from the nurses today. The new emergency regulations make merely mentioning this event, never mind publishing it, strictly illegal. So that just gives you a feel, which this was reflected obviously in the health conditions for children here at the time, and I'll go on now to talk about those. So back then, infectious diseases and vaccination. Many Black kids were not immunized. One of the results was that measles was a leading killer. It often invaded the lungs. It was especially deadly in malnourished children. 64% of South African 1-year-olds had a first measles vaccine in 1986. And as we know, you need 95% coverage for herd immunity. It just is a wickedly contagious disease. Please close your eyes for this next slide if you might be upset by a photo of a child very ill with measles. This toddler's chart read, respiratory distress needs artificial ventilation, no beds available in the ICU. And this little girl died 2 days after I took this photo. Infectious gastroenteritis was also extremely common, sometimes leading to typhoid fever if the Salmonella typhi bacterium spread through the blood. Proper isolation for typhoid fever was impossible under the hospital's conditions. This is typically how a child like this was isolated. The next photo is of a child with tetanus who's very ill, so close your eyes if need be. This is in the respiratory infectious care intensive care unit. And I just really show this to remind us of the costs of not vaccinating against vaccine preventable diseases, because we do not see this here. Routine tetanus vaccination started here in 1947. Deaths fell 500-fold in the next 60 years. Even so, if you get tetanus unvaccinated in this country today, you have a 13% chance of dying. I'm off the upsetting slide now for those who close their eyes. So with South Africa's first democratic presidential elections in 1994, the crumbling of the apartheid regime, Nelson Mandela became president, and he immediately instituted universal free healthcare for pregnant women and young kids. A national vaccination program soon followed, both adding vaccines to the routine schedule and doing these mass measles and also polio vaccination campaigns where they would give kids up to age 14 catch-up vaccines. Very effective. It was badly needed because the child mortality rate as Mandela took power was 60 deaths for every 1,000 live births, deaths before 5 years old, that is. In the US at the time, for comparison, the number was 10. So what about infectious diseases and vaccination now? So I found Mo Herndon Archery, the head of pediatric infectious diseases at the King Edward Hospital in the summer of 2022. He had been working there for 30 years, almost continuously. And so he's a useful reflection of both then and now. He said when he was a young doctor, we had an entire ward of gastroenteritis. We had a ward for Salmonella, Shigella. We've closed all of those down now. he adds, today, in the past year, I've probably seen one patient with typhoid fever. Shigella, we don't see that often. Cholera is a rarity. Why? Well, another early initiative by the Mandela administration in the 90s was to improve sanitation. And so even into the first 2 decades of this century, that's been followed up on, so that there's been a 20-point rise in people with access to flush toilet, a ventilated pit latrine, or a composting toilet since 2000. And this is just one of the many papers that demonstrate that diarrheal morbidity and mortality in under 5s falls when you get kids clean sanitation facilities into their homes, clean water into their homes. Vaccination rates have also leapt more than 20 points since I was there, to a record 87% of kids now in 2021 in South Africa had a first measles vaccine. Consider too that that was in the heart of the pandemic. And still, it's not enough, heading hopefully for that 95% still. Democratic South Africa also led the continent in introducing new vaccines as they came online. Haemophilus influenza in 1999, which gives young kids meningitis, which is just wicked. Strep pneumonia, the pneumococcal conjugate vaccine in 2009 causes, particularly in vulnerable kids, pneumonia and meningitis, and rotavirus in 2009. And this was also a big piece of the reduced diarrheal admissions that Dr. Archery explained to me. Again, just one paper, but the association of both diarrheal admissions to hospital and deaths falling on the heels of that 2009 introduction of the vaccine. Still, all is not entirely well, and as is the case, I think, often in lower and middle income countries, getting kids into the clinic for the whole schedule in that second year of life is a tough sell, and they're struggling with that in KwaZulu-Natal as elsewhere. 70% of 2-year-olds with second measles vaccine. HIV, then just barely on anyone's radar when I was there in '86. By 1990, it's ablaze. By the 1990s, it's an inferno. And in the early aughts in South Africa, it's a self-inflicted tragedy, because as antiretrovirals become available, AIDS denialist Thabo Mbeki becomes the president in 1999. He literally refused donations of antiretrovirals from major Western pharmaceutical manufacturers. And you see what happens on this mortality curve in the middle there, starting really in 97, 98, it just starts to climb for under 5-year-olds and really does not fall again until antiretrovirals come online after Mbeki is forced out of office. It was just such a preventable tragedy for these young babies. Dea Moodley was there at the turn of the century trying to get the Mbeki government to take these things on board, at the vanguard of fighting mother-to-child transmission, and she still is doing that these 30 years later. And what she says is, in the 90s, literally 1 in every 3 women without access to ARV therapy transmitted the infection. So her paper actually out of the King Edward Hospital in 1996 is footnoted. They found a 34% rate of women transmitting to their fetuses the virus or during lactation in women who weren't on ARV. This is just another way of looking at that mortality graph I described, or that was a couple slides back. I hope it's, oh good, it's visible. So you just see the purple or red fraction of death from HIV/AIDS in under 5-year-olds in 2000 is at 37%. As Mbeki insists on not medicating, it climbs to 47% in 2005. By 2010, he's bending and allowing some therapy, although he's now been forced out, and that's at 28%. And then finally in 2012, as it recedes in the youngest 0 to 5-year-olds, neonatal deaths and perinatal mortality take over as the leading cause of under 5 mortality, which they remain to this day, by the way. HIV now. So in a small village in rural KwaZulu-Natal in the summer of 2022. I met Sandees Wazandi, who likes school and wants to be an airline pilot and lives in an, hut without running water, without electricity, her parents scrambling to even get food on the table. But she said to me, she plans to stay away from boys. And by the way, the modern day photography is done by Gulshan Khan, who's a South African photojournalist who's just excellent and really illuminated our story. And this is her photo, as are the others from today, or from 2022. So Sandizwa has good reason to stay away from boys. The percentage of South African girls aged 15 to 17 who are HIV positive, 4.3%. But by the time they get to antenatal clinics and are pregnant in their later teens, early 20s, in fact, this figure represents all women at antenatal clinics. And this was the year, I think, 2018, who are HIV positive, 30%. And in KwaZulu-Natal, which has by far the leading HIV rates in the country, 41%, which was just a stunning number to me. I don't know if it is to you, maybe you all know more than I do, but I was just utterly floored by that number. So why? Kwarisha Abdul Karim of the University of KwaZulu-Natal and others documented a pernicious cycle in a landmarks paper out of rural KwaZulu-Natal in 2017. And it showed that what was happening was that older men were infecting virus-naive younger women who were then growing and then marrying later. And basically, older men were having sex simultaneously with same-aged women who were already infected and also infecting younger girls who would grow older and then infect older men. So it's a vicious cycle that is known to be perpetuating the epidemic. And the quote from Kwarisha Abdul Karim is, "We have a cycle of transmission where men 25 to 40 having sex with women of their own age-ish and women under 25. And that's why we continue to see high rates of new HIV infections. That young woman is a key part of sustaining the HIV epidemic in Eastern and Southern Africa." However, there at least has been progress for newborns, thanks to aggressive testing and treatment at antenatal clinics adopted in the aughts. And that was 34%, as you recall, from 1996, of infected pregnancies having transmission to the fetus. That number was down to 3% in 2012. Infrastructure and access then and now. So our story opened with Nosifo Mashangu of Mafakatini because she had a story to tell that represented the progress on infrastructure. She was 28 when I interviewed her. She had been born literally on the eve of liberation in late 1993. And she had been born at the side of the road in her village because her mother was waiting for a bus that didn't come to take her to a Roman Catholic health clinic an hour away because there were no facilities in Mafakatini. Nosifo herself got pregnant at age 14. And by then there was a health clinic. So that would have been 2007. There was a government health clinic in Mafakatini. They saw that she was going to be a high-risk pregnancy because she was so young. They sent her by ambulance to the tertiary care center in Pietermaritzburg, the provincial capital, and she delivered her son there smoothly and without incident. So that just shows you all the progress that has been made. And in fact, in the 1990s, the new government refurbished 263 health clinics, built 1,345. Today, there are more than twice as many local clinics and community health infrastructure, whether it be clinics or small hospitals. They're available within 5 kilometers to more than 90% of the population, which is just huge, as I'm sure you appreciate. Some tertiary care facilities have upgraded. This is the pediatric casualty emergency room at the King Edward Hospital today. I will note to you, though, that it was built through charity and not on government funding. The government is just strapped, and much of the hospital, many of the buildings are still from 1936. Problems abound. Salim Abdul Karim was actually assistant superintendent at the King Edward Hospital in 1990. He said it was an era when white managers barked orders at black staff, and it's clearly much better now in that regard. But our healthcare services are on a path to ruin, he says, and he puts this down to several issues: the decrepit infrastructure nationwide, systemic corruption, which undermines both clean running water and electricity. I mean, there are rolling power outages. That's a given of life in South Africa because the power grid has been so compromised by corruption. Incompetent management at some hospitals, he calls out. Lack of access to high-end healthcare for many. 23 ICU beds for more than 3 million kids in KwaZulu-Natal province. And this was a photo I took last summer of like one of the entrances to the King Edward. It could have been 1986 for what I was looking at. Here's Aneli Makani with her daughter Svale Thunzi, age 4, outside the King Edward Hospital last July. Svale has bad eczema, and Aneli brings her frequently to the King Ed, where she can get free medications for and tertiary, a specialist to look at Svale. She really is grateful. She says the government has our backs, but if she could, she would take her daughter to a private hospital because the lines are so long here. And she says that, you get to the head of the line, you get seen, they prescribe 10 medications and the hospital's out of 5 of them, which is, just the reality. Care at the King Edward and other government health facilities is on a sliding scale according to income. Many people like Emily will not have to pay anything at all. Now, this is in a squatter settlement on the edge of Durban. It's a Islamic Medical Association charity clinic. And the woman pictured, Nakwanda Mkise, with her sick 8-month-old daughter and her niece, prefers coming here to going to a nearby government health clinic because she knows she will get prompt attention and she knows she will get medication. At the nearby free government clinic, medications are often unavailable. Another patient mom I interviewed on this same day at the same clinic said she had come here because yesterday she'd gone to the government health clinic and been told to go buy her own paracetamol for her child. Sister Hani Ali, who's been working in the trenches in this squatter community for 30 years, says the government provides, quote, the square root of bugger all to people in the shanty town. She is the IMA's nursing director. Professor Refilo Miskela, who heads pediatrics at the King Edward Hospital and the affiliated medical school, says the primary problem is a socioeconomic problem when people live without adequate housing, without adequate food, access to electricity and water. That cannot be fixed by the health system. And yet, despite everything, pediatric mortality, kids dying before their 5th birthday, is down to 33 deaths before age 5 in South Africa in 2021 compared to 1994. The US number today is also lower, 6.3 in this country. So a long way traveled for South African pediatric health and a long way to go. And with that, I'm happy to take any questions. And also I'm going to remind you to please complete the survey. I'll flip back to this QR code in a minute, just so that you can take down an email if you have follow-up questions.
Thank you so much, Marcia. Any questions?
That's great. Thanks very much. I'm interested in your personal story about the migration away from medicine to journalism.
Right, yeah.
And then kind of, back to medical journalism. Can you talk a little bit about your motivations for that and how that happened?
Sure. So the short version is I grew up in a medical family. My mom and dad met in an operating room. She was a nurse. He was a surgeon. He had a very strong personality. And he was determined that I would be a doctor. And whereas most kids, age maybe 18 or 19, have that knockdown, drag out fight, I didn't have that knockdown drag out fight till I finished medical school. And so this knowledge of wanting to be a writer, I mean, which I'd had since I was probably 9 years old, just grew and grew, and then kind of came to fruition during this time in South Africa, which was near the end of my medical training. And so after I finished med school, I went to journalism. And yeah, kind of the rest is history. That, yeah, it is. It's kind of rare. And I guess I have to write about that because people keep asking me to write about that. So, yes.
Very interesting. So I'm curious also again about your story, but the story of how were you able to go during the apartheid region from, I believe, to Stanford to there? I mean, what was the connection? How was that even possible?
Right, it was through, so I was a medical student actually at Oxford by the time I got to my pediatrics elective, or my elective, and I did it in pediatrics. And that was, you know, a place very well connected with South Africa. And one of the physicians there who knew I was interested in pediatrics and public health said, you really got to go work with Jerry Cavadia. He's the man, and he's in Durban at this thing. And so, you know, I met German medical students there. I met, there was, for medical students, for whatever reason, there was no prohibition on coming. And in fact, I imagine that tourists were also welcome to support the economy, first willing to go there in those days. So I don't think the regime would have been so happy if they'd known I had this little Minox camera in my pocket and was running around playing undercover journalist, which, you know, I almost got in trouble a couple times. But from medical people who were like, you are going to get us in so much trouble if they find you taking these photos, stop. So I was, I operated at the edge of the permissible in those days. I was pretty strong-willed and whatnot. So, but yeah, and I don't think they were probably too happy with the article when it came out. I don't know if they clamped down on medical visitors after that.
You have a question on Zoom, which is, as South Africa continues to progress, do we see more Black nurses and doctors? And also, what was the impact of COVID on this center and the other healthcare centers in South Africa? So
Right.
two questions there.
Right. I'll take the second first. The impact of COVID, according to Refilo Mescala, who headed pediatrics at the King Ed, and it still does, was that it was a catastrophe. Not so much through the direct contracting of the disease by kids, but because their parents were sickened, schools were closed. Many kids get 2 meals at school in South Africa. Their parents lost their jobs. I mean, so that's where it hit kids, and they're still recovering. In terms of Black nurses and doctors, yes, more, but not enough, I would say. And certainly the senior leadership, you'll notice a lot of the folks I interviewed were South Asian. There's a very strong South Asian ancestry contingent in KwaZulu-Natal that you would not necessarily find in other provinces, but that's really clearly evident. Hospital management, I think, is really devoted to bringing up more Black staff, more Black physicians like Refilo Mescala. So hopefully that changes. It's been several decades, so you do wonder.
I've always wondered in situations where you have HIV prevalence in the 30, 40 to 50% range in antenatal care visits, and enormous stigma about HIV status. Why in the world don't we just treat everybody that walks into the clinic? No, don't bother to test them. Don't do it. Just put them all on antiretrovirals, at least through the end of their pregnancy. The current antiretrovirals, don't have anywhere near the same level of adverse events that we had before. They avoid all the stigma because nobody would know who was positive. And we could beat down that 3% is still embarrassing. I actually don't believe that 3%.
You think it's higher?
I think it's higher. And even if it is 3%, it's unacceptable, given what we can do today. So it just seems to me that we've hyper medicalized this situation such that we're not thinking on a population basis. Sometimes, there's lots of people, oh no, you can't treat people who actually don't have the disease. So we often treat people that don't actually have the disease. And yeah, so that's something I've been bugging my HIV friends about for years. The other thing that I'm interested to hear your perception on is current vaccine coverage rates. So, they're clearly getting to the qualified WHO 80+% range. But one of the challenges with WHO's criteria, of course, is it's a cross-sectional assessment among kids between 12 and 24 months, which is fine, and that is an issue. But if you, so for example, think about pneumococcal vaccine, getting pneumococcal vaccine at 40 months is a very different efficacy against pneumonia than it is if you get it at 6 weeks, starting at 6 weeks. Because the intensity of the infection load is early in very young children. You wait till you're in your 3rd year of life, the efficacy is going to be very, very minimal because there's actually not that much pneumococcal disease in those kids anymore. They survived it.
Is that where it is on the schedule at 40 months?
No, that's where it actually happens. So if you assess if your criteria for a successful coverage is kids between 12 and 24 months, at least for pneumococcal and for HIV, you've missed the high-risk group, potentially the high-risk group. And the studies that have been done at our site in Southern Nepal and a number of other sites that actually look at specific timing show that somewhere in the range of 70% of all those vaccines are at least 6 to 8 months late. They're not on schedule. So well, one of the challenges we have is that this WHO coverage criteria is nonsense. It's not capturing what we really need to know.
I want to go back for a minute to your first comment and ask, in the antenatal setting, do you think that injectable long-acting antiretrovirals could have the same effect? I mean, just every woman gets a shot. That seems a lot easier than being dished a bunch of pills you're going to have to take and take and take and take.
Yeah. But no.
Oh, okay. Does anyone in the audience know? Please chime in if you do.
Online.
Feel free to just unmute yourself and talk as well.
Yeah.
You don't have to chat.
Just from a broad picture, you're laying out a little bit of hope, but you're also very gloomy with some of the pronouncements that people that you quoted. I mean, is there any hope or any light that could come to future improvements in the situation, or I mean, is there a political movement or motivation, health system side, to actually increase things, or are we looking at a stagnant or declining?
I fear it's the latter, but I'm no kind of expert on South Africa. But when Salim Karim said our healthcare services are on a path to ruin, that really caught my attention. I think the problem is so much political with vested interests, found corruption, right up to the level of the presidency, fractious politics, riots between usually Black warring factions. It's just, I don't know how it gets remedied. I worry. I really felt it with the rolling power outages. I was just thinking, I happen to have sleep apnea, and so the machine would go off in the middle of the night. And I would just be like, is this the best you guys can do? Really? You have so much in this country. Anyway, so I could offer more hope, and I hope I'm proven wrong.
A question about neighboring countries. We're so close to South Africa, some years, others. Have you looked into how these improvements have have happened or not happened in those countries, or what's the effect of South? Because I know that they rely a lot on South Africa. I work in Zambia, so.
You know, I don't know. I'm no kind of expert on those countries. Can't answer, sorry.
Any other questions?
No, it's nice to see somebody else benefiting from Pulitzer. We have students that get connected to the Pulitzer Center with journalists,
Yes.
specifically.
Great. So
Yeah, we have.
Pulitzer funds public health students as well.
But we fund
Fun.
the opportunities for public health students to get partnered with journalists through Pulitzer.
Okay, cool.
Thank you so much.
Thank you all.
Next week, we'll be doing child development in global context with Dr. Lee Feltzbach from Harvard, so come next week. Thanks. Emily will be back.